How does one know whether you have a sacroiliac joint dysfunction or a herniated disc? These are two types of problems that give very similar symptoms, but without even taking an X-ray or an MRI, you can figure out how exactly the pain started or is originating from. And I've been a chiropractor for over 29 years. I have a lot of experience dealing with this. I have seen ungodly amounts of patients come in with their MRIs claiming they have a herniated disc, yet they have no symptoms of a herniated disc. You adjust their sacroiliac joint, pain improves dramatically, and they tell you, where have you been all my life? Likewise, I have patients who think they have piriformis syndrome or they have something else, and it turns out it's clearly a herniated disc. And I'm going to give you the benefit of my experience, and I'm going to teach you exactly how, even before you take an X-ray or an MRI, you could figure out where your pain source is. And once your pain source is identified, then the treatment becomes very clear. In addition to that, you're not going to waste time. Why waste time? Why do all these stupid exercises trying to fix a problem where you don't even have that problem? So hopefully it'll save you some time. Now first let's figure out what the hell we're talking about. A herniated disc is a tear of part of this structure right here in between the bones. And what happens is when it tears, the analogy is always the disc is like a jelly donut. So the outside of the donut tears and the jelly squirts out. And that's what you see right here, right this red. Okay, this one's normal, this one's normal. And because it's so close to this yellow thing, this is a nerve, very often you will get pain that goes down the leg along the nerve. So you could literally determine where the herniated disc is by the person's symptoms, which we'll discuss in just a moment if you hang tight, based on which nerve, because you know where the nerves go. Is it the big toe? Is it the little toe? Is it the bottom of the foot? Is it the top of the foot? You can figure out pretty much which side the disc herniation is on and also which nerve it is. That's very beneficial. Now a sacroiliac joint dysfunction is right here, right where you see this line on the inside, and on the outside there's a line. Now this piece, this whole pelvis, is what I'm touching right now. If you put your hands on your hips and just as if you're mad at someone, you know, I'm sure if you've had your wife do this to you, she puts her hands on her hips, she's putting her hands on these pieces here. So let's do the first one. Let's talk about the first symptom that differentiates between a sacroiliac joint pain and a disc origin pain. The first is the ability to either sit or stand and walk. Now, a person with a herniated disc is going to have an extremely difficult time sitting for a long period of time, whereas a person with a sacroiliac joint pain is going to feel better when they sit. Very often, almost by accident, they figure out that if they spread their legs apart, they feel better. It's just weird. But what they don't realize they're saying is when they spread their legs apart when they're seated, they're compressing the sacroiliac joint and making it more stable. Whereas with a herniated disc, you're actually compressing and putting load on the disc material, and it starts to swell out more and pinch the nerve. The second thing and second symptom is when they go from a seated to standing position. So usually I'll observe this. In my office, I'll ask them, does it hurt more when you sit or stand or walk? And they'll say, oh, it hurts more when I sit. And I go, okay, go ahead and stand up for a second. Let me just check something. And I tell them I'm checking their posture. But I'm actually very carefully observing how they go from a sitting to standing position. Very often, a disc herniation patient will get up, kind of flex, but they won't have a catch. Whereas a person with a sacroiliac joint problem, their joint will catch. They'll come up and they'll go, ugh. That's usually what you're looking for. Now, a herniated disc usually will feel better if a person walks around. And the reason why is because as the person is walking around, they're getting little micro movements and exchange of nutrients and a pumping action on the disc, and that relieves the disc. Whereas with the sacroiliac joint, usually when they walk, it'll actually hurt worse. So those are clues. The second thing that I kind of ask for is tell me exactly where your symptoms are. Now, usually with a herniated disc, the person will describe the sensation of leg pain greater than back pain. That's important. And they'll tell me that their leg feels like it's burning, it's tingling, it's numb, there's sharp prickly feelings, anything where they describe it like that. And they'll literally point to where it is, and what they don't realize is they're pointing to the exact nerve. So in other words, if they point to the big toe, usually that is the L4, L5 disc. If they're pointing to their little toe, it's usually the L5, S1 disc. If it's the front of their thigh, along their knee, down their shin a wee bit, that's usually L3. L2 discs and L1 discs are more rare just because of the biomechanics of the spine, so you just don't see that a lot. And occasionally a person will have what's called Main syndrome, which is sometimes it's a herniated disc, sometimes it's more facet joint, but it's up higher and it'll give more back pain than leg pain. It won't give any leg pain at all. So we don't worry about that in this video. That'll be another video in the future. But the person will literally point to the nerve. Whereas with a sacroiliac joint, they'll have pain and they'll grab their butt right here. In other words, they'll have more back pain than they will leg pain. That's important. And they'll describe it as going down into the hamstring. The patient will call it sciatica because when you Google, gee, I have leg pain, what do you think the algorithm does? It doesn't diagnose you. It's not asking you questions. It gives the most general answer, which is sciatica. And then the person starts Googling sciatica and goes down that rabbit hole, and pretty soon, before you know it, playing cards look like they're walking around and marching, and you got someone with a big head. It's a weird movie. Did you see the Johnny Depp movie with that? That was really weird. Nonetheless, I change my mind sometimes. I lose track. All right, let's get back into it. Sacroiliac joint. So the sacroiliac joint will very often give pain more in the back than the leg, but it will refer down into the leg, into the hamstring. Now, interestingly enough, if it's really bad, a sacroiliac joint, it'll refer down into the calf, skipping the knee. That is so important that it's almost diagnostic. So when a patient goes, yeah, it's down in the back of my leg and into my calf, you ask them questions like, do you feel it in your back of your knee? And the answer is usually no. Sacroiliac joint dysfunction. So what I do in my office is then, once I ask all these questions, then I will do a physical exam. So then again, this does not include an X-ray or MRI just yet. But what I do is I test them in certain positions that mimic what I suspect. So let's say I suspect that a person has a herniated disc. I will have them, while they're seated, very often, I will have them just relax their back into a flexed forward posture. I'll have them take their hands and grab the bottom of the chair and pull up on the chair. This further exacerbates the weight distribution onto the disc. If they say, "Oh man, that's the worst," we know it's a herniated disc. If I really want to torture the person, I could do a straight leg raise or various orthopedic tests. So in that position, then I will have them extend the leg. They light up. They're usually off the chair at that point. So we don't really want to torture patients and make them hurt any worse, but it's a way to confirm. So you could do this yourself at home. Just flex forward, grab the bottom of the chair, pull up, and then whatever leg is numb, try to straighten your leg. If it causes worse pain, you've very likely got a herniated disc. Now usually with that type of test, a sacroiliac joint doesn't hurt at all. Doesn't make any difference whatsoever. But then what I'll do is I'll have them stand up and I'll have them hold on to a doorknob or something, and I'll have them march in place as if they're trying to step up and skip a step going up a flight of stairs. That's how I describe it. And then what I'll do is, just so I can visually see what's happening, and there's something very interesting that happens when you do this, is I'll take my thumbs and I'll place them on what's called the PSIS and the S1. And when they raise this leg, this one should move and drop. When they raise the other leg, this one should move and drop. There's a fancy word for this called nutation, counter nutation, all these different things. But ultimately what I'm looking for is, does the sacroiliac joint move? And the answer is, if you notice a discrepancy from side to side, number one. Number two, that it's mimicking the patient's pain. So as the patient is raising the legs, which is an exaggerated version of walking, they're going, "Boy, that really hurts." Or you see them hiking up the hip. That's clue number two, it's sacroiliac joint dysfunction. But here is the most fascinating part, and the thing that sets this diagnosis apart that you will never see on an X-ray or an MRI, is that, let's say the patient has discomfort on the right hand side. I'm going to say 60 to 70% of the time the sacroiliac joint is stuck and not moving on the left hand side. That doesn't make sense to most people. Shouldn't the tight side be the painful side? And the answer is no. I'm going to tell you why. Because when you have a left and right side, they work together. If the left side is not moving well, your body is going to try to protect that by tightening muscles around the area. And then as a compensation reaction, because we have to walk, we have to get around, the right side will move in an abnormal way or an excessive way. Very often there will be more tenderness here because it's inflamed along the sacroiliac joint. And because it's a compensation reaction, inflamed and moving excessively, think of instability, the patient will get more symptoms on the opposite side. Usually I personally see this when the problem is a chronic case, when the person has had this pain for a long period of time. If it's a new problem, well, I tried. Hold on one second. Okay, I'm back. What I was saying is, the fascinating thing about the sacroiliac joint is sometimes when the joint initially loses its range of motion, the patient will get symptoms on that particular side. But if they don't get it fixed or it never resolves, then as time goes on, their body starts to adapt to that problem and then starts to compensate, and they'll get worse pain on the compensated side. So here's the thing that a lot of patients just can't wrap their head around, but once you explain it, they can, is that the patient has symptoms on their right side, but I'm going to adjust the left sacroiliac joint. And when I adjust the left sacroiliac joint and it restores its motion, and now it's balanced, the right side starts to come down. This is where patients think that you're just a freaking miracle worker. Like, why didn't anyone figure this out? How did you do that, doc? Usually I tell them, ancient Chinese secret. But it's really not. It's just analyzing and understanding the differences. Now, when does an x-ray come in with this type of problem? The answer is, it really doesn't. An x-ray will give you ideas as if there's a fracture. So if a patient fell down a flight of stairs, we'll take an x-ray. Sometimes you can look at an x-ray and there'll be a definite discrepancy between sides. But to me, in my humble opinion, radiating their pelvis, where their sex organs are, their uterus, their ovaries, their testicles, and then when you x-ray this area, you take enough space that you're x-raying also their kidneys and their adrenal glands. You don't want to put too much radiation into a person's glands if you can't, unless it's absolutely necessary. So we can determine if a person has a sacroiliac joint dysfunction without an x-ray simply by listening to the patient, gathering some information, and doing an exam. And that way, no x-ray is necessary. Now, a disc herniation, here's the reason why an MRI is of value. Because an MRI is really going to tell you the severity, the size of the herniated disc, and whether the patient is more likely to need surgery versus not need surgery. So it's really a pre-surgery procedure. 97% of all disc herniations do not need surgery, which means you've got a 3% chance that you're going to need surgery, right? But most of the patients that I see, you don't necessarily need an MRI right away. Because if you know it's a herniated disc and you send the patient for an MRI, and yes, it's a herniated disc, the treatment is exactly the same. By doing stabilization exercises that I have on my YouTube channel, you could just look them up. You give them stabilization exercises, you adjust the area to restore motion into that area, you do anti-inflammatory style of treatments, meaning you change their diet to give them an anti-inflammatory diet. You can use ice, you can use a lot of different movement methods to get fluid exchange going. You teach them to take breaks so that they don't sit for 8 hours a day. Most disc herniations can resolve through natural methods. So you don't necessarily need an MRI, except for if you're thinking the person needs surgery. And also, in California, which is where I practice, everybody wants to sue everybody. So usually you just send the patient for an MRI just to cover your tail. But it never, hardly ever changes the results of the treatment. I had a patient who had an 11 millimeter disc bulge. It was confirmed by MRI. And I thought for sure this guy needed surgery. And so I sent him to a surgeon for a consultation. The surgeon didn't want to do surgery right away, so I worked on the patient for about 6 months. The disc herniation is now only 3 millimeters. He can tolerate things, he can play golf, he can do a lot of different activities now. I had another patient who had a 6 millimeter disc bulge, again, confirmed by MRI, but didn't really need surgery. Worked on that patient only for about a month and a half, and they feel 90% better already. These are just normal things that occur in our office that are pretty standard. But imagine if a person had a sacroiliac joint problem and I treated it as if the person had a herniated disc, or I just gave them standard exercises, figure 4, stretch the piriformis, pull your knees to your chest, that type of treatment, you'd get nowhere, and the patient would be very frustrated. So unfortunately, in the disease care system we have, very often you'll go to a doctor and the first thing they'll do is take an x-ray, irregardless of what type of symptoms you have or what type of injury you've had. And then they will usually give you anti-inflammatory medication. And then if that doesn't work, send you for an MRI and refer you to the surgeon. Yet no one actually sits down and says, what are your symptoms, to differentiate between these two, let alone actually do the exam and go from there. The phone keeps ringing. I got to get to the phone. I hope you found this video interesting. If you have any questions, ask in the comments. Have a great day.